So, this is week 7, cough and dyspnea. This week's objectives, the learning outcomes, to differentiate between acute and chronic cough, identify differential diagnosis of acute and chronic cough, choose diagnostic tests for acute and chronic cough based on the likely differential diagnosis, interpret results for diagnostic testing ordered for patients presenting with cough, differential diagnosis of dyspnea. And we are done. So we're going to start with cough because cough is one of those most common symptoms that patients seek healthcare, and it can be tied to so many different things. And obviously it's one of the most important things because it helps keep our airway clear. So what you're going to see is you've got to figure out where's the location of the cough, what's the receptor. So if you think about it, the cough starts with a location, and you've got several places it can start with. It can start with the larynx, the trachea bronchi. It can even start from ear canals and eardrums, pleura, pericardium, diaphragm, esophagus, and stomach. So what you've got to think about is what's triggering it. It could be triggered from a mechanical stimuli, airway, smooth muscles, contraction, gastric acid? Is it from various chemicals? Is it cough receptors that are stimulated by mechanical stimuli such as a postnasal drip? And then what happens is that reflux stimulates and follows along the vagus nerve, and it's going to go to the cough center, which is located in the medulla oblongata of the brainstem. However, other anatomical locations can be stimulated and initiate the cough reflex, including the pleura, the pericardium, ear canals, esophagus, and stomach. Just to name a few. So you've got to think about that. Then we got to think about how effective we are coughing, and that is really triggered by the force in which they're getting their cough and what's going behind that force. And then you've got to kind of think about the muscles that are behind it, and the effectiveness of the cough depends on the strength of the respiratory muscles, which affect the depth of the inspiration, and the ability to cough. The effectiveness are those that don't have that ability to effectively cough are greater risk for pneumonia. And so we really want people to get deep breaths, cough hard. That keeps the pneumonia away. So that's what we are talking about, is how deep do the coughs go, how hard, and are they using those ancillary muscles? So that's why you got to think about where that cough is coming from. So what you need to remember about a cough is a symptom. It's not a disease. So we have to figure out what is the disease state or the cause of the cough. It does account for 30 million visits annually each year. Women are more likely to develop cough as a symptom of chronic cough. They are, as a sex, they are more likely to have a chronic cough. And among the chronic coughs, they are more likely to get a heightened severity of chronic cough. So women, aren't we lucky for that? Cough, we actually categorize it according to how long someone's had it. So an acute cough is usually resolves within 2 to 3 weeks, less than 3 weeks. from the onset of the illness, and usually you're going to think of it as caused by an upper or lower respiratory infection or disease. More than likely it's upper respiratory. It could be allergic rhinitis, acute bronchitis. It can be a pneumonia. You might consider congestive heart failure, pulmonary emboli, or aspiration when you see this. A subacute cough is 3 to 8 weeks. And your chronic cough is greater than 8 weeks and is defined as persistent. In individuals who do not smoke, a chronic cough is commonly caused or triggered by a postnasal drip, asthma, bronchitis, bronchiectasis. Also, don't forget to think about your angiotensin converting enzyme inhibitors. Don't forget that. That might be a little hint to you guys. Because those ACE inhibitors can cause that chronic cough, and you want to always ask patients what meds they're on, and don't forget that it can cause that chronic cough. Also, something else to think about with this is gastroesophageal reflux disease. Many times that can be identified with a chronic cough, and patients will sometimes even mention that they notice a sour taste, and I'm sure we're going to talk more about that, but I always like to mention that while I'm mentioning this here. In patients who smoke, chronic bronchitis is the most common cause of a chronic cough, although we do not want to miss lung cancer. And somebody with a chronic cough, long-term smoker, ex-smoker, that's a do not miss lung cancer, especially if they're losing weight. But chronic cough, ex-smoker, smoker, you don't want to miss that diagnosis. Like I said, when you're talking acute cough, you're thinking upper respiratory infection, you're thinking those viral things, you're thinking acute bronchitis, asthma, COP, exacerbations, pneumonia, foreign body aspiration, other infections, pertussis, histoplasmosis. Don't miss PE in this person either. So what you have to think about is when you're analyzing the diagnosis of an acute cough, you've got to make a decision. Is it life-threatening? Is it non-life-threatening? And that's what this is looking at. It's going to take you down, okay, if it's life-threatening, what is it? You know, if you're thinking your life-threatening things, you're thinking, is it a pneumonia, severe asthma, exacerbation, or a COPD exacerbation? Is it congestive heart failure or pulmonary emboli? Is it non-life-threatening? That is like that upper respiratory infection. Is it something environmental? Something that we don't have to panic over, but we can treat. It's just you want to know how quickly you need to act in this situation. So your first step is to rule out life-threatening etiology. So you're going to start asking these questions. Does the patient present with dyspnea or shortness of breath or chest pain? Was the presentation sudden or insidious? Does the patient have a history of COPD, asthma, or CHF? Is the patient febrile, and if so, how high is the fever? What is the general health status of the patient? What is the current oxygenation level compared to the baseline oxygenation? Is the patient tachycardic or bradycardic? Is the patient normotensive, hypertensive, or hypotensive? Is the cough productive? What is the quality and amount of the sputum? So your foreign body aspiration is usually going to present with a degree of airway blockage, And it's going to depend on how much of that is blocked. You're usually, and where the location of the blockage is. Age, typically we're going to see this in kids. What type of object they put in. Many a times it's coins. I'll be honest, it's coins. Or those little erasers. And the elapsed time since the event. If there's respiratory distress, cyanosis, altered mental status, that's an emergency. They're going to get life support and rigid bronchoscopy immediately. Most common symptoms can be a cough, tachypnea and stridor, focal monophonic wheezing, decreased air entry. You will not usually see wheezing, cough, and diminished breath sounds are not usually your presenting symptoms though. They usually do present with some air passing, and kids are usually fairly calm. Usually the mother's the one that's not as calm. But if they still have airway passing, I mean, many times we still have to do the bronchoscopy to get the object out. But if we can keep the child calm and comfortable while we're doing it in a much not panicked fashion, is much better for everybody involved. Signs and symptoms are based on the location of the foreign object. If it's laryngeotracheal, it's not very common, but they're going to present with stridor, wheezing, dyspnea. Foreign bodies in this location are, like I said, not common but extremely dangerous, and this is an extreme emergency. And they're going to present with respiratory distress. Typically, it's going to be in the large bronchi. They're going to present with coughing, wheezing, occasionally hemoptysis, shortness of breath, fever, and cyanosis. Your right bronchi is most common, followed by the left. They can have it in the lower, children can get it in the lower airways. They will present with a cough. And you will sometimes even see where they have, where children have delayed symptoms, where they have symptoms after their initial episode. Like they initially cough and then they don't have symptoms, but like a cough, a delayed cough later, and you're going to see those delayed presentations where you know they've had a choking episode, and then you see they have an infection or a fever or pneumonia later on. Then you start, if you know there's been a choking episode, then that's a delayed presentation of a foreign body episode. Usually you can assume that in 75 to 92% of cases, that's a foreign body aspiration, especially in a child that was previously healthy. If you know they had a choking episode and then resolved and then follow with dyspnea and cyanosis later. If you're seeing these delayed infection, inflammation, pneumonia, you will do a chest x-ray And if it is negative and you really suspect it, you might do, and they're still symptomatic, you might get a CT scan if you don't see something on chest x-ray. Or you could go straight to rigid bronchoscopy if you're really certain that it's a foreign body. But many of your occult foreign bodies are going to result in recurrent pneumonia. So just keep that in mind. So pneumonia is an infection of the lower respiratory tract caused by bacteria, viruses, fungi, protozoa, and parasites. Pneumonia is categorized as community-acquired, hospital-acquired, or ventilator-associated pneumonia. Community-acquired is one of the most common reasons for hospitalizations in the United States, and is the one we're going to focus on this slide. Infections, it's associated with infections of the lung parenchyma. Its risk factors are associated with age. The older you are, the more associated you are with having a community-acquired infection. Chronic lung diseases, including asthma and cystic fibrosis, bronchiectasis, edema, pulmonary edema, bronchial obstruction due to stenosis, tumor, or foreign body, lung cancer, and previous episodes of pneumonia, presumably due to scarring, all put you at risk for community-acquired pneumonia. So, risk factors for community-acquired pneumonia includes anything that puts them at risk for aspiration. It doesn't have to be just stomach contents. It can actually be any upper respiratory aspiration. Also, meaning saliva. They can aspirate saliva. An alteration in level of consciousness, such as if they've had previous stroke, a seizure, they're taking an anesthetic type drug, alcohol intoxication can put them at risk. They have dysphagia due to esophageal lesions or motility problems. They wear dentures while they sleep, can put them at risk for this, of aspiration. Other risk factors for community-acquired pneumonia includes immunocompromising conditions such as diabetes, HIV, a solid organ, or a hematopoietic stem cell transplant. Immunosuppressive medications used for tumor necrosis, factor alpha inhibitors, or chemotherapy puts patients at risk. Medications for sedatives, PPIs, H2 blockers, and antipsychotics can also put them at risk. Sedatives make sense because why? It makes them sleepy, they're more unconscious, they can aspirate. Antipsychotics, they aren't sure the connection there, to be honest. What's interesting with the PPIs and the H2 blockers, they don't really think it has anything to do with the medications themselves. They think it's more the type of patient that gets put on them. So if you think about who gets put on H2 blockers and PPIs, think about it. It's your reflux patients. They priority aspirin due to other reasons. Community-acquired pneumonia risk factors. They're associated with metabolic disorders or malnutrition, uremia, hypoxemia, and acidosis. Your lifestyle factors and environmental exposures associated to community-acquired pneumonia are smoking tobacco, alcohol use, toxic inhalants, overcrowding in our jails and shelters, homelessness. Many of our elderly are homeless. We don't realize that, but they are. Instrumentation of a respiratory tract. mean if they had a recent bronchoscopy, they're at risk for this. Viral respiratory tract infections, especially influenza. So if they have influenza, they are at risk for developing viral pneumonia, which then leads to bacterial pneumonia, and then they're at risk for developing Staph aureus in particular. Community-acquired etiologies, there are greater than 100 different microbes. Our bacterial ones are typically Strep pneumoniae and Streptococcus aureus, and are M. pneumoniae. Also, we do get rarely Legionella pneumoniae and M. Catarrhalis. But those are more rare. You can have viruses such as influenza, parainfluenza, and RSV. Your immunocompromised is where you're going to start seeing more your fungal infections. You will sometimes see histoplasmosis or histoplasma with different, depending on where people live, your smokers, and that's sometimes location too of where people live. Your Cryptococcus, you're going to see more in your immunocompromised, your PJP, and your valley fever. Your immunocompromised host also is the fungi and S. aureus. With community-acquired pneumonia, they can present from mild to severe. Usually it's going to start with a viral upper respiratory infection. They can have fever that can be up to or greater than to 101, chills, a productive or dry cough, malaise, pleural pain, sometimes even dyspnea, and they can even present with hemoptysis or that rusty sputum, especially with S. pneumoniae. They can have the side chest pain, like I said, that pleural pain, and they can get pulmonary consolidation, and if they do get that, you can do percussion and you will get a dullness over that. They may get inspiratory crackles, increased tactile fremitus, and when you listen to them, you can get this egophony, a prolonged A heard on auscultation when they say E. So that's one thing to listen for when you're listening to them. An atypical presentation in patients greater than 65 is they may not have any symptoms other than altered mental status. They can have a blended temperature. Your gold standard, I'm going to say this again, gold standard for pneumonia is a chest x-ray. That's what your go-to is to diagnose this. So, the National Heart, Lung, and Blood Institute and the World Health Organization say COPD exacerbations are acute increase in symptoms beyond the normal day-to-day variation. So what they're saying is one or more of the following cardinal symptoms. A cough increases in frequency or severity. Sputum production increases in volume and or changes character. Dyspnea increases. The non-cardinal symptoms include increase in chest tightness and discomfort, sleep disturbance, anxiety, and fatigue during exacerbations. Chest radiographs are usually unchanged. Most COPD exacerbations are due to respiratory infections, and you're going to see an increase in insidious cough, and that's usually a complication of an increased upper respiratory infection. So we're going to talk about asthma now. And so when we're talking about asthma, if you have, for mild exacerbation, you can have a cough, wheezing, shortness of breath, chest tightness, fatigue, and even reduced exercise tolerance can be part of that. And even breathlessness is part of that mild exacerbation. Patients will get a severe exacerbation. They're going to show that real fast breathing, that greater breaths of greater than 30 breaths a minute. They're going to have tachycardia, greater than 120 breaths or 20 beats a minute. Use of those ancillary muscles of inspiration, especially those sternocleidomastoid muscles. They're going to have diaphoresis, inability to speak in full sentences or phrases, inability to lie supine due to breathlessness. They're going to sit up forward. They're going to be leaning forward, trying to get breaths. They're going to have a pulseless paradox, a fall in the systolic blood pressure by at least 12 mmHgs during inspiration. These are all indicative of severe asthma. If you're seeing that. They can have, if they have fever, sputum, bradycardia, chest pain, that can be indicative of a pneumonia, bronchiectasis, anaphylaxis, a pneumothorax in one of these patients. What they do is you do a peak flow meter, and that peak flow meter is based on their sex, height, and age, and that gives us kind of an gauge on what's normal for them. And then what you do is that's kind of their gauge to know what's normal for them. So they get their base. And if they get a decline of 20% of what is their base normal, then they're in an asthma attack. If they, from what their personal best is, if they are less than 50% their norm, then they're in a severe asthma attack. If you see that they have, if they're exposed to a trigger and they get sudden shortness of breath and a sudden cough, they're in an asthma attack if they have some trigger. Keep that in mind. So CHF exacerbation is associated with cough, progressive shortness of breath, orthopnea, proximal nocturnal dyspnea, weight gain, leg edema, occasional frothy sputum, and progressive dyspnea is the most common complaint of mild compensated heart failure. So PEs, they have a wide variety of presenting features, and these can be from no symptoms to shock to sudden death. Some of your most common signs and symptoms could be shortness of breath, chest pain, cough, deep vein thrombosis, Well, I will tell you, most patients are going to present with dyspnea and chest pain. Most patients are going to have a cough and symptoms of a deep vein thrombosis somewhere. It is rare for them to present in shock and total dyspnea. But I will tell you, it's rare for them to have shock and arrhythmia, for sure. I will tell you, though, some rare also is hemoptysis, is a very unusual presenting symptom. You want to keep in mind that this can have mild, non-specific symptoms. So you don't want to miss this. So keep this in the back of your mind. I can tell you from experience, I've thrown PEs twice. Both times they were missed. Both times I was treated as asthma exacerbation, and it was missed both times. The first time I definitely had PE, I had deep vein thrombosis symptoms in my leg. I even told them my leg hurt. I even told them I thought I had a blood clot in my leg. I think it broke off, went to my lungs, and they scanned my leg, would not scan my lungs. Even asked for a D-dimer, they refused. So it was missed. I was put in the hospital for asthma, released, put in the hospital again for asthma, and released, and put in a boot for my leg. Went to see ortho, and he scanned my leg, found the deep vein thrombosis, then I was put in for PE for a week. So the second time, everybody's treating me for asthma, and they ran out of things to give me for my asthma, and I ended up seeing a walk-in doc that took one look at me, and he's like, do your arms or legs hurt? And I stopped in my tracks and looked at him, and I said, no, why are you asking me that? And he said, why do you have that look on your face? And it was because I'd thrown PEs before. So as soon as he asked me if my arms or legs hurt, it was a huge red flag in my mind, because I wasn't even remotely thinking PE. In my mind, I was thinking asthma. As soon as he asked me, I was like, don't even ask me if my arms or legs hurt. I didn't have pain in my arm or my leg. Did have a blood clot in the same leg, but because it wasn't a full occlusion, I didn't have the pain. And so that's why I didn't realize it, because I didn't have pain in my leg. That leg's always slightly swollen, so I didn't catch the swelling. But scarred my lungs again. So both times I got lucky, survived it. Neosamon, Xarelto for life. But always have in the back of your mind PE. Just keep that in mind.